Morning students, today we are going to discuss one of the very important topic and it is also very interesting also. So we are covering today jaundice. So what is jaundice? So basically it is a French word derived from French word jaune means yellow, jaundice means yellow disease, means something related with yellow color. So coming to jaundice, definition of jaundice. Definition of jaundice, it is a yellowish discoloration of skin, sclera and mucous membrane due to increased concentration of bilirubin in blood, which is deposited in various tissues of the body. So, it is most important chemical in this is bilirubin. What is the normal concentration of bilirubin in blood? Can anybody tell? Yes, 0.5 to 1 milligram per deciliter. This is a normal concentration, and when this concentration increases beyond 2 milligram per deciliter, then yellowish discoloration of skin starts, and now we can call it as jaundice. So, what is an important diagnostic test? What is a basic test we do in our daily life? How we diagnose that the person is suffering from jaundice? So, we are just looking into the sclera of eye, that whether they are yellowish discolor. If they are yellowish discolor, we say that yes, the animal or patient is suffering from jaundice. Why we are looking at the sclera? Because the bilirubin pigment, which is responsible for jaundice, it is having highest affinity towards elastin tissue, and elastin is present in the highest concentration in case of sclera. So, we are looking into the sclera. So, what is jaundice? Jaundice is discoloration of skin because of increased concentration of bilirubin. So, we need to have some knowledge about bilirubin. What is bilirubin? How bilirubin is produced? How it is evacuated from our body? What is the metabolism of this bilirubin? So, students, from where this bilirubin comes in the blood? So, students, more than 80%, most of the bilirubin come in the blood by the disintegration or digestion of the red blood cells, erythrocytes in the mononuclear phagocytic system of our body in the spleen, liver or bone marrow. So, in these organ, mononuclear phagocytic system cells are there. They disintegrate, cleave these RBCs, erythrocytes and produce bilirubin. How bilirubin is produced? Let us see. So, this mononuclear phagocytic system, they digest this RBCs, whether they are senile, sometimes they are immature, sometimes they are parasitic. So, these RBCs are recognized by our mononuclear phagocytic system and they are disintegrated and cleaved. Now, after cleavage, three products, we are getting three types of product. Number one is globin, number two is heme, and third one is iron. Iron is converted into hemosiderin and is stored, and second one is globin. Globin is a protein and it is reutilized by the liver. So, third one, which is an important one in our context, is heme. Now, heme is engulfed, when mononuclear phagocytic cells engulf these RBCs, they are disintegrated and this heme part is converted into biliverdin by the enzyme heme oxygenase, and this biliverdin is again converted into bilirubin by the enzyme biliverdin reductase. Now, we are having this bilirubin. Now, this bilirubin is insoluble and toxic also. So, this bilirubin cannot be transported from one place to other place, and as I told you that this bilirubin is toxic. So, we need to detoxify it. How we can detoxify it? We can detoxify it by the liver. So, this can be transported to the liver and liver is detoxifying this bilirubin. So, since it is insoluble and toxic, so to make it soluble or to transport it, it is combined with the albumin, and bilirubin albumin complex, it is transported to the liver. And this bilirubin albumin complex in blood, it is known as unconjugated bilirubin, and this bilirubin cannot be filtered by urine. This is a very important part, that unconjugated bilirubin cannot be filtered by urine. Now, coming to liver. Now, the bilirubin came into the liver, it goes to the endoplasmic reticulum. Here the detoxification takes place by the enzyme glucuronyl transferase, and this process is known as glucuronidation. So bilirubin is converted into bilirubin glucuronide by the process known as glucuronidation, and it is also known as conjugation. So after that bilirubin glucuronide is formed. So before liver it is insoluble, toxic, and in the liver it is converted into bilirubin glucuronide, which is soluble and non-toxic. Since it is soluble, we can excrete it, we can evacuate it. So this bilirubin glucuronide is secreted by the means of bile ducts, bile. So this is secreted by the bile in the GIT, intestine, and in the intestine we know that millions of bacteria is there, millions of gut microflora is there. These microflora act on this bilirubin glucuronide and convert into urobilinogen, and this urobilinogen, 80% of urobilinogen is secreted into the feces. It gives color to the feces, brown yellow color to the feces, and remaining 20% is again absorbed from the intestine, and it goes to enterohepatic circulation. While circulating into enterohepatic circulation, some of this urobilinogen is escaped from blood, and it can be, since it is soluble, can be filtered by the kidney, and it appears in the urine, and it gives characteristic color to the urine, that is pale yellow color to the urine. So in this, so what is by this process you might have know that what is the role of liver. So simply liver, what liver is doing? Liver is doing the unconjugated bilirubin, which is produced by the disintegration of RBCs. They are detoxified by the means of process known as glucuronidation, or it is known as conjugation, and conjugated bilirubin comes out from the liver. So before liver it is unconjugated, after liver when it is exiting it is conjugated. It is a soluble and non-toxic, it is insoluble and toxic. So by this diagram we can frame out what are the basic regions of increase in the bilirubin. Suppose there is a excessive disintegration of RBCs, or RBCs are broken down by some of the agents, virus, bacteria, or n number of agents are there. So many RBCs are break down, and it is beyond the capacity of liver. So RBC breakdown is more, so more of unconjugated bilirubin is produced, and it is not conjugated by the liver because liver is having certain capacity. Okay, so we are having increased bilirubin. Now we can call it as jaundice. Now second one, if there is suppose normal disintegration, means normally old and senile RBCs are broken down by the mononuclear phagocytic system when they complete their life cycle. So there is a normal disintegration, but there is a problem in liver. In liver, suppose there is an injury may be caused by bacteria, viruses, and some of toxic agents. So there is a problem in liver, and what liver is doing? Liver is conjugating the bilirubin. So problem is in liver cannot conjugate the bilirubin. So again there will be increase in bilirubin level, and increase in bilirubin level is called jaundice. Okay. Now third thing, suppose there is a normal disintegration, normal destruction of the RBC, and here liver is also normal, liver is also doing all the functions normally, but there is an obstruction of bile duct, means bile duct is obstructed. So this conjugated bilirubin will get rise, and you know this conjugated bilirubin is a very soluble, it is having a wide distribution. So you will get very high intense yellow discoloration of skin and sclera or mucous membrane, and since it is soluble it can be filtered from kidney. So you will also get urine, dark color urine in this. So coming to types, so depending on what type of bilirubin is increasing blood, we have categorized this jaundice into three types. Number one is prehepatic jaundice, second one is intrahepatic jaundice, third one is posthepatic jaundice. Means problem is before entering into liver, it is known as prehepatic. When problem is in liver, it is known as intrahepatic or hepatic or toxic jaundice. And third one, when the problem is after liver, means liver is conjugated, the problem is obstruction in bile flow, then it is known as post-hepatic or obstructive jaundice. The name of pre-hepatic is also hemolytic because there is a hemolysis. RBCs are broken down in excessive number. Okay, so in this I have told you earlier, there is a the bilirubin which is increasing is unconjugated, and here in post-hepatic the bilirubin which is increasing, it is conjugated. Okay, now coming to what are the regions, it is very important to know regions because in that way we can treat the animal. So something which is causing hemolysis, excessive hemolysis or RBC destruction. So in veterinary practice, it is a very important that hemoprotozoan disease, some of the hemoprotozoan disease which are well known nowadays, some of the protozoan parasites, they live in the RBC, some of the parasites which are not living in the RBC, outside RBC, but they can cause damage to the RBC. These all are known as hemoprotozoan parasites which cause destruction of RBCs. Some of the example is babesiosis, and another one is anaplasmosis, hemobartonellosis, trypanosomiasis. These all are blood parasites, they can cause damage to the RBC. So hemoprotozoan disease. Second one is bacterial disease, Clostridium hemolyticum. Third one is a viral disease, equine infectious anemia. This can also cause damage to the RBC, excessive damage to the RBC. Now this fourth one is it is a hemolytic disease of newborn. Students, we are getting this disease in human beings also. In human beings you might have heard about erythroblastosis fetalis. In this, Rh negative mother conceives from Rh positive father. So there is chances of excessive destruction of RBCs. So these all can cause excessive destruction of RBCs, technically hemolytic, hemolysis. So they are called prehepatic jaundice, and in this the level of unconjugated bilirubin increases. Okay, and another important thing is impaired conjugation. What is impaired conjugation? Students, you might have heard about two important diseases in newborn babies. One is pneumonia and second one is jaundice. The jaundice in the babies, in newborn babies, is physiological, not a pathological, because the enzyme required for conjugation is glucuronyl transferase, and this glucuronyl transferase, it is having it attains its peak activity in 2 weeks. So 2-week period is for attaining this glucuronyl transferase activity. So conjugation not take place, or less conjugation takes place up to 2 weeks. So there is a physiological jaundice. Now coming to intrahepatic jaundice. So as I told you, intrahepatic means problem is in hepatocytes. There is a destruction of hepatocytes, and liver is responsible for conjugation, detoxification or glucuronidation. So these processes cannot take place in the liver. So any agent which is causing damage to the liver cells, they can cause hepatic jaundice or toxic jaundice or intrahepatic jaundice. So there are n number of agents. Two important bacteria, Salmonella and Leptospira in veterinary practice, and one of the virus, infectious canine hepatitis, which is caused by the adenovirus. One of the important plant toxin, Crotalaria plant, can also damage the hepatocytes or liver cells. Another is phosphorus poisoning. Phosphorus poisoning can also damage the liver. So whenever there is a damage to the liver, conjugation will not take place, and there will be increase in the bilirubin, and we can call it as jaundice. Now coming to third one, post-hepatic jaundice. It is also known as obstruction jaundice. As I told you earlier, there is a obstruction of bile flow. So what are the example? One of the most important example is Fasciola hepatica. We know that what is the life cycle of Fasciola hepatica? Fasciola hepatica lives in the liver. Its life cycle is in liver and bile duct. They lay egg in the bile duct. So they may cause obstruction of the bile duct. So another example is Ascaris in pig. Ascaris not lives in bile duct, but what is happening when Ascaris number is more, they can obstruct the opening of bile duct. So bile flow is obstructed and increase in bile pigments. Third one is tumors and inflammation in the vicinity of bile duct. Suppose there is a one bile duct and in vicinity of the bile duct there is a one inflammatory swelling or some abscess is there or some tumor is there. It can cause pressure on the bile duct. So there is again the flow of bile duct is impaired. So there is an increase of bile. Again, one more example is gallstones. Which is a very common. They can also cause obstruction to the bile flow, and again there will be increase in the conjugated bilirubin. So these are three different parts, and one is prehepatic, hepatic and posthepatic. Now coming to diagnosis, how we can diagnose the jaundice. Basically jaundice in daily practice we can diagnose by looking into the sclera, skin or mucous membrane of gums. But some of the tests are there. I am only discussing two. One is icterus index. Icterus index is actually old diagnostic test. In this, plasma and serum color of the patient is matched with the known concentration of potassium dichromate. So this test is basically subjective test because my eyesight can differ from your eyesight. So it is a subjective test and it is not having much importance. The important is Vandenberg test. This Vandenberg test is why important because it not only diagnose but also differentiate three types of jaundice. So how we can perform? We can mix plasma with the airless reagent. If we are getting intense pink and purple color immediately and which is intensified within a 1 to 2 minutes, it is called direct positive test. How it is coming direct positive? It is because of increased concentration of conjugated bilirubin, and conjugated bilirubin increases in case of obstructive jaundice. Now second one, no color appears within 2 minutes, but after 10 minutes, within 10 minutes the golden color appears. Now we can call it as indirect positive. Indirect positive is because of increased concentration of unconjugated bilirubin. So unconjugated bilirubin increases in hemolytic jaundice. Now third possibility is brown red color instead of pink purple color within 1 to 2 minutes, and which is becoming pink and purple within 10 minutes. This is known as biphasic reaction which occurs in the toxic jaundice. Now this is a table I have taken from the Weigert second edition, page number 60. So to differentiate different type of jaundice. So if students, somebody is asking that in which type of jaundice out of 3 you are getting highest yellow discoloration of skin, sclera, or highest yellow color in the urine. So what will be your answer? Your answer will be obstructive jaundice, because obstructive jaundice there is a soluble conjugated bilirubin increases in the blood, which is a soluble compound and it is having wide distribution. So the highest intensity of yellow color will be in obstructive jaundice. Similarly, highest yellow color of urine in the obstructive jaundice, because conjugated bilirubin can only pass the urine. Okay, and icterus index is nothing but the plasma color, which will be also highest in case of obstructive jaundice. Now, what is the color and consistency of feces? So students, you know bile. What is the function of bile? Yes, function of bile is to emulsify the fat so that it can be absorbed from the intestine. So if bile duct is obstructed, bile flow is obstructed, then what will happen? Bile will not come into the intestine and it will not emulsify the fat. And when emulsification of fat will not be there, this fat will not be digested and appear in the feces. So feces will appear fatty or greasy. So instead of normal feces, you will get greasy feces in case of obstructive jaundice, because bile salts, bile is obstructed, bile is not coming into the intestine. Second one, the important part is bile gives color to the feces. Your feces are brown or yellow color. It is because of bile pigment. If bile is not coming into the intestine, the actual color of feces you will not get. So instead of getting yellow brown color, you will get clay color or gray color of feces. So this part, and most important, Vandenberg test to differentiate, I have told you earlier, indirect positive in case of hemolytic jaundice, direct positive in case of obstructive jaundice, and both या biphasic reaction in case of toxic jaundice. So I think I have cleared most of your doubts, and you can differentiate different type of jaundice, and accordingly we can go for treatment of jaundice. So any questions of yours is most welcome. Thank you.